1689, a physician named Dr. Richard Morton documented what is now considered one of the earliest known medical descriptions of anorexia nervosa. His patient, a young woman named Miss Duke, was the teenage daughter of a wealthy English merchant. She was described as emaciated to the utmost degree, her skin pale and almost translucent, her pulse faint but steady. Despite her fragile condition, she insisted she felt well, save for a strange distaste for food that had taken hold months earlier. Morton initially suspected tuberculosis, the common wasting illness of the time, but when no signs of infection appeared, he concluded something else was at work. He called it nervous consumption, a wasting away of body brought on by not by disease, but by sadness and anxious cares. What he didn't know then, and what modern psychiatry now knows, is that Miss Duke's case was one of the earliest recorded descriptions of a psychological disorder tied to self-starvation. Centuries later, the core features remain hauntingly familiar: the denial of illness, the distortion of body images, and the complex interplay between mind and body. What began as a puzzling medical mystery in Morton's time is now a well-defined category in the DSM-5, feeding and eating disorders, but the human struggle at the heart of it has changed very little. Welcome to the Licensure Lifeline podcast. This is your host, Matt Lawson, and today's episode kicks off what I'm thinking is going to be a 5-part series on conditions and pieces of the DSM-5. The DSM-5 is as close as psychologists get to religious texts for our profession, right? Like, this has all the stuff in it, all the issues, how we treat them, things like that. So, it tends to be a big part of what we're tested on. So I'm really hoping that digging into some pieces here a bit are really going to just help you be really well informed for the test. And I'm going to kick things off with the eating issues, feeding and eating disorders. This is actually a field that is near and dear to me, or an area that's near and dear to me. One of my first clinical jobs out of school was working for an eating disorder clinic that had both inpatient and outpatient, and it's something I really fell in love with, supporting these individuals, which could be really tough at times. The feeding and eating issues can be extremely difficult to treat and just to see people struggle with. But I also found it extremely rewarding, and it's something that I have come to embrace with the work I continue to do with people. And I still do see individuals that struggle with eating and feeding issues. All right, now before we get into the core material for today, I have a special announcement for in the news segment that I've been doing. So for the last couple of months, I've actually been working on an app. And this app is going to be something that people can use, anybody that has a license or a certification, and it will allow you to upload your license or cert, and it helps you track CEUs associated with it. It has notifications on it that lets you know when it's getting close to renewal time. It just gives people a nice place to keep all of their licensure/certification information. For now, I'm putting it out to my therapy community. It's definitely something that can be used in a variety of different fields, really any field that requires a license or cert. But it's great. It's something that I've been working on for a bit, and I'm really excited to get it out. So I'm announcing it now, and my hope is to have it up and going, and I will have a link for everybody next week to check it out and see how it works, and see if it's something that could support you with your professional life. So more to come with that. I will announce all the real stuff, where you can go and how you can find the app in the next episode. For now, it is going to be a web-based app. I'm still working on the mobile version, so that will hopefully be out by the end of the month. But you can get going with it hopefully as early as next week. All right, for the study stack today, I have a bit of a new drill that you can use to help you study. It's going to really help you boost your recall speed. So this is called the 1 minute drill. And the way it works is you pick a topic, let's say anorexia, and you go over it. You read it over, look it over, whatever. Then you set a timer for exactly 60 seconds. And without looking at notes, write down everything that you can remember about that disorder, diagnostic criteria, hallmark symptoms, treatment approaches, risk factors, even cultural considerations, everything that you can remember about that disorder in 60 seconds. Stop when the timer goes off and just take a look at what you got down. Compare it to what the DSM-5 says or what some of your other notes say, and then try to do it again. So with this, it's going to teach your brain to recall this information as quickly as possible. Let's get into the main information around feeding and eating disorders. These are a distinct category in the DSM-5 that encompass a range of conditions characterized by disturbances in eating behavior and related thoughts and emotions. They go far beyond dieting or picky eating and often involve significant medical, psychological, and social consequences. Remember, with anything, it tends to be how it impacts the rest of your world as to whether or not we're looking at it as a disorder or not, right? So you can have somebody that's a picky eater, you can have somebody that's dieting, and it not necessarily impact other areas of their lives in a significant way. There are some people that may argue that, but I'm thinking specifically of friends and family that have done things like intermittent fasting, and we've had to change entire schedules around when they're allowed to start eating. Things shouldn't be as rigid as that anyway. But off the soapbox and back to this category of disorders. So some of the key features here. First off, you have a persistent disturbance in eating or eating-related behavior that results in altered consumptions or absorption of food and significantly impairs physical health or psychological function. Another key feature is there's a broad scope here, right? It includes disorders that occur across the lifespan from infancy to childhood. So you have stuff like Pica and rumination, which I'll get into a bit more, which you see oftentimes in adolescence. And with adulthood, you see things more like anorexia, bulimia, and binge-eating disorder. And it's also important to remember that it's not just about food. These disorders are often driven by complex psychological factors such as body image disturbances, perfectionism, control issues, a traumatic history, and anxiety and other mood disorders. But one of the big things that is really unfortunate about a lot of these eating disorders is it's very high risk. And amongst like psychiatric disorders in general, anorexia disorder actually has one of the highest mortality rates due to both medical complications and suicidal risk. I remember my time working in inpatient and outpatient the eating disorder clinic. A lot of the times, clinicians would describe this as slow suicide. And if you've ever dealt with an eating disorder or know somebody that has an eating disorder, like you can understand how it can be kind of looked at as that. You are slowly starving yourself to death. It is definitely one of the more tragic aspects of this psychological disorder in particular, and something that you oftentimes see when you work in this area. Let's do a quick breakdown of each category, and then I will further discuss and get into some more detail here. But first, you have Pica. That's P-I-C-A. This is a persistent eating of non-nutritive substances for at least 1 month. And with a lot of these, you're going to see time matters with as you often see with a lot of other psychological disorders, the time here matters. So 1 month of non-nutritive substances. So you'll see people eat string. You'll see people eat rocks. Pica can cover a broad range of things that just have no nutritional value. Rumination disorder, this is repeated regurgitation of food, not due to a medical condition, and this one lasts over at least 1 month. So people that throw up for no other reason than other than just making themselves throw up. Next, we have Avoidant Restrictive Food Intake Disorder, ARFID. You'll often see it, the acronym ARFID, ARFID. And this is avoidance or restriction of food intake leading to nutritional deficiency, weight loss, or dependence on supplements without body image disturbances. Next, we have anorexia nervosa, restrictions of energy intake leading to a significantly low body weight, intense fear of gaining weight, and a disturbance of body image. Next, bulimia nervosa, recurrent binge eating followed by inappropriate compensatory behavior such as vomiting, fasting, or excessive exercise. I saw bulimia nervosa probably more than any of the other ones when I was a personal trainer, actually, working out of a gym on a college campus. And it's, it was just something that was unfortunately a part of the culture that you'd see. You'd see people oftentimes eating a lot and then exercising a lot. I've actually had to pick people off the floor that had passed out on treadmills. Next up, you have binge eating disorder, recurrent episodes of binge eating without compensatory behavior, and other special feeding disorders. This is kind of like the other blanket category or an umbrella category that covers anything else that seems to be related to eating and is causing some psychological or physical disturbance. So that's the acronym OSFED. All right, that was the quick overview. Let's get a little bit deeper into these issues. So first up, Pica. Now, with this one, like I said, you're getting into non-food substances for at least 1 month. And this can be anything from picking your nose, eating dirt, clay, chalk, paper, hair, soap, ice, just to name a few. Risk factors here are nutritional deficiencies, especially iron and zinc. You will see sometimes pregnant women eat things that would be considered non-nutritional, trying to get minerals. If they have if they have some kind of deficiency there. But you also see people on the autism spectrum disorder. This is something you often see with these individuals and other people that have intellectual disabilities. Treatment for this is going to be nutritional supplements. Of course, we're not going to be prescribing nutritional supplements, but just to let you know. And then behavioral interventions, and then addressing the underlying cause. So underlying causes for something like Pica, it's very impulsive. This disorder is extremely impulsive. So a lot of the times people even aren't really aware of the times they do this. The other thing that you see is that, there's a lot of anxiousness around this type of disorder. It's something that people potentially do that, are just trying to assert some sense of grounding for themselves. So they may engage in this behavior. But to help you remember this, think of Pica, Pix, peculiar. So Pica equals picking or eating peculiar non-food items. Pica, Pix, peculiar, the PPP. Sound good? Next up, rumination disorder. This is repeated regurgitation of food that lasts at least 1 month, which may be re-chewed, re-swallowed, or spit out. This is not due to any medical condition like something like GERD. But the key features here, it's often painless, can lead to malnutrition if prolonged. Sometimes it is linked to neglect or a stressful environment. That goes for Pica as well. Treatment for this is our behavioral techniques, habit reversal. So this is, rumination disorder can kind of fall under that a habit creation area. So you're trying to reverse the habit. Diaphragmatic breathing, addressing psychosocial stressors. Memory trick for this one, think ruminate equals re-eat. Ruminate equals re-eat. So rumination is about repetitive regurgitation, not obsessive thinking, despite the similar name. Next up, Avoidant Restrictive Food Intake Disorder, ARFID, ARFID. So this is the one, restriction of food intake leading to weight loss, nutritional deficiencies, dependency on supplements, or interactions with psychosocial functionings not due to lack of food, cultural practice, or body image concerns. Key features here include this can actually stem from sensory issues, fear of choking or vomiting, or a lack of interest in eating. This often is seen in children, but it can often persist into adulthood as well. But treatment here would be gradual exposure to new foods, nutrition counseling, CBT for anxiety and fear. All right, memory trick, ARFID, ARFID. This equals avoids food, but not for looks. Okay, so there isn't any body image disturbances typically connected with ARFID here. There may be, this is going to help you differentiate between something like anorexia, which there is that significant body dysmorphia associated with anorexia, but not with ARFID. Anorexia nervosa. This is restriction of energy intake leading to significant low body weight, intense fear of gaining weight, and disturbances in self-perceived weight or shape. The subtype here is you have restricting type and binge eating / purge type. A lot of medical risk associated with anorexia nervosa, including things like bradycardia, hypotension, osteoporosis, and this has, again, a high mortality rate. I've seen cases where people have had heart attacks. Young individuals have had heart attacks that have anorexia because their electrolytes get so low in their bodies that the electrical impulse that causes the heart to beat gets all out of whack, and it causes them to have a heart attack. Treatment for this is going to be nutritional rehabilitation, psychotherapy, of course, and medical monitoring. So a lot of the times when you're working with somebody that has anorexia, you're going to be a part of a team that includes doctors and nutritionists to really monitor and support the individual. Next up, we have bulimia nervosa. So recurrent binge eating with compensatory behavior like vomiting, laxatives, fasting, excessive exercise. In order to have this diagnosis, it has to happen at least one time a week for 3 months. And then self-evaluation unduly influenced by body shape and weight. Key features include weight usually is normal or slightly above, which is something that can really throw off a lot of people. Because I think individuals, they hear eating disorders and we immediately go to somebody that's just emaciated and skinny. But a lot of times with bulimia nervosa, you have individuals that would appear normal weight, but there's a lot going on inside, right? So you don't have oftentimes underweight individuals, not nearly as much as you have like with anorexia. Treatment here is going to be CBT, SSRIs, nutritional counseling. Test memory trick. Think bulimia equals binge, then balance. They try to balance out the binges with purging or over exercising. On the test, remember frequency once a week for 3 months and differentiate from binge eating disorder. And finally, binge eating disorder. So this is recurrent binge episodes without compensatory behavior, at least one time a week for 3 months. Binge eating episodes feature things like eating rapidly until uncomfortably full, large amounts when not hungry, eating alone due to embarrassment, feeling disgusted afterwards. There is a lot of, like, with a lot of these eating disorders in general, there's a lot of shaming. But with binge eating, that is one of the key features that you see oftentimes is this shame around what the person has just done. And I've seen people bounce in and out of binge eating disorder a lot. So, they'll work on it. They'll have periods of just feeling great, and then fall back into binge eating pretty regularly or easily. And the reality of it is it's such a coping skill that they've developed for themselves. Granted, all these eating disorders are coping skills that people have developed for themselves. But with binge eating, it's one of those things that, food is socially acceptable. And, you can eat a lot of food a lot of the times, and people just kind of like nod and agree, like, oh, you're just eating a big meal, right? Or, it's not that big of a deal. But then there's this shame cycle where they shame themselves, they feel bad, they eat even more. Okay, a little memory trick for this one. Think bed, B-E-D, binge with an E at the end, B-I-N-G-E, without dumping, B-E-D, bed. The binge happens, but no compensatory behavior is associated with it. Last one, other specified feeding or eating disorders, OSFED. This is clinically significant symptoms of feeding or eating disorders that cause distress, impairment, but don't meet full criteria of any of the other disorders I just discussed. So atypical anorexia, you meet all anorexia criteria except you don't have a low weight. Bulimia nervosa, but with low frequency, kind of what I was describing before, where you see people just kind of binging or engaging in bulimia or binge eating disorder, but it's just not as frequent, not enough to make it a diagnosable condition. And so the treatment's all dependent on this one. I think this, out of all of these is the OS, other specified feeding or eating disorders, pretty easy to remember. It's just anything that just doesn't meet the criteria for one of the diagnoses I just discussed. All right, let's get into some questions that you might see on the NCE. A 9-year-old boy has been eating paper and chalk daily for the past 2 months. His growth is normal, and there's no cultural practices of ingesting these substances in his family. Which of the following is the most likely diagnoses? Rumination disorder, Pica, avoidant restrictive food intake disorder, or anorexia nervosa? This one's going to be Pica. Pica involves a persistent eating of non-nutritive substances for at least 1 month, inappropriate to developmental stage and not culturally sanctioned. Rumination disorder is repeated regurgitation, remember. Then you have ARFID, that was one of the options as well, anorexia. Question number 2. A 26-year-old woman binges on large amounts of food twice a week, then induces vomiting to prevent weight gain. This has been occurring for the past 4 months. Her BMI is 23. Which diagnosis fits best? Would it be bulimia nervosa, binge eating disorder, anorexia nervosa, binge/purge type, or OSFED, OSFED? Answer here is going to be A. This is bulimia nervosa. Bulimia nervosa involves binge eating with compensatory behaviors. You see this individual was eating food twice a week and then induces vomiting. And remember, it's 1 time a week at least for 3 months. Next up, which of the following features best differentiates avoidant restrictive food intake disorder, ARFID, from anorexia nervosa? Is it A, significant weight loss, B, nutritional deficiency, C, lack of interest in eating, or D, disturbances in body image? Remember this one, the hallmark difference is that anorexia nervosa includes a disturbance in body image or intense fear of gaining weight. Next up, A 14-year-old girl presents with a history of eating very little for several months. She expresses fear of gaining weight despite being underweight. Her BMI is 16. She has not had a menstrual period for 6 months. What is the most appropriate first step? A. Begin cognitive behavioral therapy. B. Start a selective serotonin reuptake inhibitor. C. Admit for medical stabilization. Or D. Recommend a high-calorie diet at home. This is danger zone stuff, right? So admit for medical stabilization. In severe anorexia nervosa, similar to what was described, with a dangerously low BMI, 16 is extremely low. When women lose their menstrual period, that I think it's 15% and below. Well, maybe it's closer to 17%. And below, oftentimes women will lose their menstrual cycle. Don't quote me on that. I can be completely wrong. But this is a severe case, and you want to get this individual into medical treatment as quickly as possible. Last question. A 32-year-old man reports eating large amounts of food very quickly, often when not hungry and feeling disgusted afterwards. He denies vomiting or other purging behaviors. This has been occurring weekly for the past 4 months. Which of the following is this most likely? Bulimia nervosa, binge-eating disorder, anorexia nervosa, binge/purge type, or ASFED, OSFED. Answer, binge-eating disorder, B. BED, remember, involves recurrent binge without compensatory behavior, at least once a week for 3 months. How about a vignette? Sarah is a 17-year-old high school senior. She comes to your office with her mother. Her mother says that she has noticed recently Sarah's been skipping family dinners, wearing baggy clothes, and avoiding eating in public. Over the past 5 months, Sarah has lost 18 pounds, and she's now 5'5" and weighs 98 pounds. A little history on Sarah. Sarah reports feeling huge and says she needs to get control over her body. She exercises for 2 hours a day, often waking up at 5 a.m. to run before school. Her menstrual periods have stopped. She hasn't had them for the past 3 months. She denies purging behaviors such as vomiting or laxative use. There's no history of substance use or self-harm or psychiatric hospitalization. And she does not have any medical conditions. Her mental status exam shows she's very thin, wearing an oversized sweatshirt and sweatpants, a little bit of an anxious, guarded mood. Her thought content seems to be really preoccupied with weight and body shape. And her insight is kind of poor. She believes her weight is too high despite her size and how much she currently weighs. Additionally, Sarah has become socially withdrawn and refuses to attend events that involve food. Recent labs from her primary care shows low heart rate and mild electrolyte imbalance. Which DSM-5 diagnosis is most appropriate for Sarah? Would it be A, bulimia nervosa, B, anorexia nervosa restricting type, C, avoidant restrictive food intake disorder, or D, other specified feeding or eating disorders? Answer here, not too hard. Anorexia nervosa restricting type, B. She has a significantly low body weight and experienced significant weight loss pretty recently. Intense fear of weight gain, disordered body image. She no longer gets her menstrual cycle. And while she says there's no binging or purging behavior, she's exercising a couple of hours a day, including before school. Another question. Which of the following is the most urgent next step? A, begin weekly individual CBT. B, referred for inpatient medical stabilization. C, start family-based therapy immediately. Or D, explore feelings about food and non-directive approach. Yeah, this one's going to be B, right? Given how low her body weight is, given that in her labs came back and showed that her electrolytes are off, she needs medical stabilization as quickly as possible. All right. Thank you for hanging with me in this episode. It was a long one, huh? I'm trying to get more content into these, and hopefully that will pay off and you'll get more out of the podcast. But thank you again. Be listening next week when I make the app announcement. And until next time, keep studying.